This is Ada Ojide from MPPA Learning TV. This video will focus on basic concepts in congestive heart failure and basic steps in medication management. By the end of this video, you will be able to identify at least 3 critical elements in heart failure management. Thank you. Brief overview of congestive heart failure. What is congestive heart failure? Congestive heart failure is a clinical syndrome or a condition that is synonymous with the inability of the heart to pump effectively. As a result, circulation is impaired and cardiac output is reduced. The main symptom profile of CHF include symptoms of pumping failure, fluid retention, and signs of reduced cardiac output. Classifications of CHF is manifold. 3 main basics for distinction include ejection fraction measurement, AHA/ACC stages A to D, which is based on the symptom index, and NYHA class 1 to 4, which is a prognostic validity tool, and also is based on physical limitation. Based on ejection fraction measurements, EF less than 40% is considered heart failure with reduced ejection fraction, while EF greater than 40% is termed heart failure with preserved ejection fraction. Classifications of AHA/ACC stage A to D and NYHA class 1 to 4. So why are these? This is more like a simplified approach with the classifications. Why are these classifications important? One, they can be used as a symptom index tool or a way for you to measure symptom severity in the clinical setting. One is a prognostic tool because it can measure future outcomes or help you to gauge patient's outcome. And it's a tool that can help to confer evidence. So those are the main reasons why those classifications are important, and also it's also important in tailoring therapy. So the classifications include AHA/ACC stages A to D, which, as mentioned before, is based on symptom index. The next category is NYHA class 1 to 4. This is based on physical limitation. So I'm going to go over them separately. So the AHA/ACC stages A to D. Stage A represents your risk factors. Stage B constitutes structural defects without symptoms. So it could be valvular disease. That's one example. Stage C constitutes structural defects with symptoms of heart failure or previous symptoms of heart failure. This stage bears clinical significance to heart failure diagnosis because it has the main clinical features of heart failure, and they are the largest demographic. This stage is also concomitant or synonymous, or it can be compared to class 2, 3, and 4 with the NYHA. Stage D just represents refractory or advanced disease despite advanced pharmacology, so maxing out all the inotropic drugs, and interventional cardiology, so despite specialized interventions by a cardiology specialist. NYHA 1 to 4, class 1, symptoms are present, however, no limitations in physical activity. Class 2, symptoms occur with regular activity, and this results in slight limitation in activity level. Class 3, symptoms are present with minimal exertion. and there's increased activity intolerance at this level. Class 4, there are symptoms at rest. Activity tolerance is severely impaired, or there is no activity at all. Risk factors for heart failure. The risk factors for congestive heart failure are manifold, and there are disorders that extend beyond the scope of this presentation. The major risk factors for heart failure include CAD, ACS, HDN, and diabetes. These constitute the largest etiological component for CHF pathology, or CHF disease process. Other risk factors include obesity, valvular disease, congenital heart disease, substance abuse with tobacco, cocaine, ETOH, renal disease, renal insufficiency, atrial fibrillation, autoimmune disease, and like I mentioned before, other etiologies that encompass this list. Population demographic include the following. Prevalence is greater in males aged 40 to 65. Prevalence is also greater in women aged greater than 75 years of age. In elderly, hypertensive patients, AFib patients, diabetic patients, and patients with aortic stenosis. And with aortic stenosis, it is also important to note that once they start having symptoms of heart failure, that is considered critical aortic stenosis, and they require immediate intervention. Epidemiology of heart failure, U.S. demographic. Below is depicted flow chart from CDC, which demonstrates the prevalence rate in different age groups in both male and female demographic. Pathogenesis of heart failure. The critical pathological tenets in heart failure include intrinsic pathological pathways mediated by CAD, MI, hypertension, which results in ventricular remodeling. Intrinsic pathological pathways just means intrinsic disease process, or disease process is mediated by pre-existing conditions such as CAD, MI, and high blood pressure. And these disease processes hasten ventricular remodeling. Secondly, remodeling of myocardial architecture results in fibrosis and hypertrophy. So remodeling of the myocardial chambers results in fibrosis, hyperplasia, and left ventricular hypertrophy or enlargement. Third, neurohormonal maladaptation versus RAS activation is a compensatory mechanism resulting in hemodynamic dysfunction, fluid overload, and more ventricular remodeling. Basically, neurohormonal maladaptation and RAS activation, they work hand in hand to attempt to try to maintain homeostasis. Reduction in myocyte-mediated cellular transport, further triggering impaired calcium transport. So there's poor permeation of calcium and poor biosynthesis of calcium. All these pathological pathways lead to increased cardiac demand, reduced cardiac output, and decreased systolic and diastolic dysfunction, which in turn engender heart failure. Diagnosis and investigations in heart failure. The focus of diagnosis should be on recognizing key clinical features as well as some atypical features that are plausible in outpatient setting. Classic symptoms include SOB on exertion, fatigue, lower extremity edema or an Asaka, orthopnea, paroxysmal nocturnal dyspnea, S3 heart sounds, pink Friday sputum, hypotension, weight gain, abdominal distension, hepatomegaly, and so forth. Atypical symptoms include GI symptoms, intractable cough, memory loss, confusion, and anorexia. History interviews should focus on questions that determine activity level, presence of cardiac disease sequela or any cardiac predisposition, presence of reactive and obstructive pulmonary disease, and presence of fluid overload. CHF diagram and schematics. So below is depicted an all-encompassing schematics or list of CHF pathophysiology and clinical features or symptoms. Diagnosis and investigation continued. Investigations are multi-pronged and includes the following: laboratory analysis, ECG, chest radiograph, and echocardiography. Labs comprise CBC, CMP, LFTs, TSH, and ion studies. These studies help to evaluate for dilutional hyponatremia, renal hypertension, hepatic insufficiency, anemia, leukocytosis, and helps in initiating inotropic drugs and diuretics. BMP is another diagnostic tool. It is released secondary to myositic stress. It's also considered an important diagnostic tool for CHF, however, must exclude other etiologies of diagnosis. Troponin levels may also be beneficial for diagnosis. Diagnosis and investigation continued. ECG may reveal left or right ventricular hypertrophy, abnormal repolarization, and atrioventricular block. Chest X-ray may reveal cardiomegaly, curly B line, bilateral lobar infiltrate, and pleural effusion. Echocardiogram is a primary diagnostic tool for CHF and may reveal reduced or preserved EF, help determine wall thickness, and valvular functions. Conventional pharmacotherapy in systolic heart failure. This includes the main pharmacotherapy in systolic heart failure and stepwise approach for management. Diuretic therapy for symptomatic relief and persistent fluid retention. Mechanisms include excretion of water, sodium, and potassium. ACE inhibitors for neurohormonal modification, vasodilation, decrease in renin and sympathetic activation, and reduction in ventricular remodeling. ARBs are primarily used for ACE inhibitor intolerance. ARNI, angiotensin receptor neprilysin inhibitor, is chemically equivalent to ACE. It helps, mechanism includes helping increase natriuretic peptides, improving diastolic function, and further reducing ventricular remodeling. A stepwise approach to follow is the following. Step 1. Start ACE because it confers the best mortality benefits for all classes of heart failure, meaning AHA, ACC stages A to D, and NYHA 1 to 4. Add diuretics for symptom relief. Step 2. Add beta blocker if inclusion criteria is met. Confers mortality benefits for NYHA 2, 3, and 4. Bisoprolol has greater tolerability effect than metoprolol and carvedilol. Step 3. Start ARNI when ACE or ARBs cannot be tolerated. Consult with cardiac specialists required for initiation. So it requires a cardiac referral. ARNI confers 20% positive clinical endpoints in heart failure management, but it's not to be co-administered with ACE inhibitor because of severe angioedema. Conventional pharmacotherapy in systolic heart failure continued based on guideline recommendation. Beta adrenergic blocker for neurohormonal readaptation, increasing ejection fraction and reducing ventricular remodeling. Avoid beta blocker in decompensated heart failure, hypotension, bradyarrhythmia, and reactive airway disease. The subsequent pharmacotherapies require specialist referral and interventions. Hydralazine with nitrates recommended for African Americans or can be used as an alternative to conventional therapy per guideline recommendations. Can also be used if persistent renal decline or increase in potassium levels. Digoxin, recommended as an adjunctive therapy, and for patients with CHF who have CHF with an AFib component. Main mechanism increases contractility via ATP interphase. Serum levels should be less than 1.2. Serum levels greater than 1.2 is linked to poor clinical endpoints or outcomes. Aldosterone antagonist recommended for GFR greater than 30, creatinine less than 2.5, and potassium less than 5. Aldosterone antagonist is considered a K+ sparing diuretic. Ivermectin slows heart rate, recommended for use in chronic heart failure with reduced ejection fraction, and also used on patients maxed out on beta blocker in sinus rhythm. Stepwise approach. Step 4. Hydralazine with nitrates. Best pharmacotherapy for African Americans and for patients maxed out on ACE inhibitor and beta blockers with persistent symptoms. Can also be an alternative therapy to ACE or ARBs. That is, if there are contraindications to those therapies. Step 5. Digoxin, adjunctive therapy after beta blocker is maxed out, confers no mortality benefits. However, it reduces hospitalization. Aldosterone antagonist, recommended for moderate to severe heart failure and recommended for MI patients with EF of less than 40%. Ivermectin, SA node inhibitor, recommended for EF less than 35% in patients with NSR or heart rate greater than 70 who are on max beta blocker dose. Or it can also be used as an adjunctive therapy for absolute contraindication to beta blocker. Thank you so much for listening to our video. This video only encompasses a subset of heart failure. It is also important to review current guidelines along with the video. We'll have subsequent videos on diastolic management and other spheres of CHF management. Thank you so much for watching. Appreciate you. Bye.